Hello, folks. Thanks for the invitation to provide some information about working with anxious youth. I'm Phil Kendall, and here we go. And as we get started, I just want to mention real quick that I over-prepared. We've done a dry run. I think it ran an hour and 15 minutes. And when Mitch asked me, he had said 35 to 45 minutes. So I'm going to talk a little quickly. We're going to move along. Thousands of cases treated, hundreds of clinical trials. I've been doing it for 34 years, and we have 40 minutes. So buckle up. Here goes. And I hope I don't do a disservice to any specific little parts of things because we're going to be skipping along. But I'm going to try to hit some highlights. So, do we want to tackle anxiety in youth? A couple of important things to keep in mind, especially when you meet with people who might not be mental health professionals. Anxiety does not go away with time. Now, some does. Some anxiety does go away. You know, a kid who grows up and is afraid of dogs or monsters, and they grow out of it. But if it's maladaptive and interfering anxiety, the more severe end, it doesn't go away with time. It usually requires some intervention, and beneficial intervention can have benefits down the road. Anxiety, when untreated or unsuccessfully treated, is associated with a bunch of sequelae, including depressed mood, substance use problems, some suicidality. So do we want to tackle anxiety? Yes. Do we want to remove anxiety? No. Anxiety is a good thing. Anxiety is an important biological alarm. It's the fight or flight kind of response, and there are times when you need it, and it's functional, and it alerts you. So we don't want to remove it. We simply want to teach kids the skills to identify it in themselves. And I used to say dial it down, but no one has a dial anymore. So thumb scroll it down and just be able to manage it. So that's our goal in working with anxious kids. Some key features: cognitive, behavioral, and parenting. There are others. These are the ones I'll highlight. From the cognitive side, I want to pay attention to thoughts that pop into people's heads, how they think about and anticipate potential catastrophes. Don't worry too much about attributions. And then the cognitive structures, their template, their mental view of things that they bring to situations. And I sometimes do this when talking about anxiety for groups of people. There'll be a room that we're in, and often it's a ballroom, and there's a hanging chandelier or a hanging video display camera or the equipment that displays the video equipment on the screen. And there'll be people sitting underneath these hanging chandeliers. They didn't notice that these were hanging over their head. The anxious person's cognitive structure, when they walk in a room, is they see the hanging chandelier and they think, I don't want to sit under it. So they bring to environments, they bring to situations, ways of viewing things that create in them unnecessary distress. We want to change that. A quick heads up to the bottom line of this talk. Verbal exchange between an adult and a kid to try to talk them out of it doesn't work. Behavioral experiences in the situation where you sit under the hanging chandelier and nothing happens has an impact on that structure. And of course, we'll come back to that. A couple of fussy things. I sometimes will hear people use the word anxiety incorrectly. You know, they've planned a trip to Italy, visit some vineyards and eat some great food, and they'll say that they're anxious to go. Well, they're really eager to go. Anxious would imply avoidance. And so I also want to be fussy with the words escape and avoidance. An escape response is perfectly legit and reasonable. You make a response, it stops a negative condition. There's an allowed alarm clock. It goes off in the morning. You turn off your alarm. You escape the negative aversive noise. It's reasonable. Avoidance, on the other hand, is a response often made by anxious people that they believe will prevent a negative condition. But it's unnecessary. The negative condition isn't going to happen. But when they make the avoidance response, they think they're preventing a negative condition. The negative condition doesn't happen, so they are then rewarded for having made that avoidance response. They're pushing the alarm or the snooze button unnecessarily. They're basically saying, I got to push the snooze button to stop the alarm from going off again, but the alarm clock's been unplugged. It's not necessary to push the snooze button anymore, but they keep doing it, and because the alarm doesn't go off, it reinforces their having made the avoidance response. It's a problem, it's treatable. And it's treatable by not letting them make the avoidance response. If they can't make the avoidance response and the catastrophe doesn't happen, we're making good progress. Let's talk about parents for a minute. And if you're a parent, I don't mean to suggest blame or assignment of responsibility here. These are just some things that parents can do. We often talk about making efforts to make it better. Let's also, just for fun, talk about how parents can make it worse. Excuse me. Intrusive involvement. Looking over the kid's shoulder, checking every detail, micromanaging. Not good. Calling a quote-unquote shrink. When a child has some distress, which every single kid is going to have multiple times, a parent's approach that is helpful is to build confidence that they can handle it. Yeah, you just had a difficult time. I know that might be hard or sad, but you can handle it. And build that resilience. If they have a difficult time and the first thing you say is, let's call a mental health professional, let's get a shrink in here, take some drugs, let's get some mental health people in here, you're communicating that they can't handle it, which of course is going to lead to initial and additional perspectives that are anxiety provoking. Mom and dad think I can't handle stuff. Tolerate negative emotions, and as you can see on the slide, intolerance is to make it worse. Negative emotions are okay. It's okay to be angry. It's okay to be sad when the justifications are there. When it gets too much, then you want to back it up. Limited risk-taking. It's good for kids to try things. Yes, they may fall, but that's how you learn. Now, you don't want them trying a high-wire tightrope unless they're quite practiced and there's a net, but limited risk-taking is a good thing. Again, we're talking about making it worse. A parent who wants to make it worse, be unpredictable and punitive. In other words, don't give any signals, but out of the blue, be punitive. That creates an environment where the child is always kind of being cautious, walking on lily pads, because you could explode any moment. Not a good thing. Modeling is very powerful. When a parent sees a bug and goes, oh my God, a bug, oh my God, jumps up on a chair and calls some bug decon company, that's modeling. And it's powerful. When a parent sees a bug and reaches down with a tissue and squishes it and throws it out and says, bugs live outside, not inside, that's good modeling. And last, and a topic that's gaining in addition to other topics as a parental factor, is parental accommodation. I'm going to take a minute to talk about this one. When a child has an emotional reaction like, I don't want to go to school, I have a test today, I'm concerned, the parent might feel some emotional reaction. In order to quell their own emotional reaction and to quell their child's emotional reaction, they accommodate. Oh, okay, you don't have to go to school. It's easier to accommodate than it is to do the quote-unquote right thing for anxiety, and that would be to have the child go to school that day. Accommodation is a parental response to anxious avoidance, and it maintains anxiety. These are all some things that we address in different ways when working with the parents of anxious kids. So, what are some things that are included in treatment? Everyone watching this probably knows exposure tasks at the bottom, and I suspect everyone also knows the variety of other factors, but I'm going to call them out for a special reason. Let's take relationship first. It's important. It's not sufficient, but it is necessary. And that is, when you're going to ask a child to do something they had been afraid to do and had been avoiding for quite a while, you need a good trusting relationship. So that's an important feature. Important, probably necessary, but not sufficient to overcome the magnitude of anxiety we're addressing. Dealing with self-talk. Everyone has it. We all have these thought bubbles with things that pop into our head. We want to not challenge or criticize their thoughts, but we want to help them think of other ways you could think about the situation. Alternate, more coping self-talk. When we come to problem solving, we like to talk about it as it's just a problem to be solved. It's not the end of the world. We learn about emotions. We do some affective education. And as is true for all CBT, homework's important, and exposure tasks. And we're going to talk about each of these with some research behind it as we get going. So, do exposure tasks rupture the therapeutic relationship? It's asked by many, many people. Here's some data. Sessions 1 to 16, each person in the treatment filling out a alliance rating. The therapist did it, the mother, the father, and the child. These are children 7 to 13. They're either receiving family treatment without exposure or family treatment with CBT, including exposure. And the statistical analyses are consistent. The change over time shows that the alliance goes up from session 1 to roughly session 6 or 7, reaches what's called asymptote, and then levels out. There's no change after it reaches its peak and flattens. Whether there's exposure or no exposure does not have a detrimental effect on the alliance. And it's important to just mention methodological features such as these questionnaires were filled out by participants, but the person who asked them to fill it out was not the therapist, it was an RA. So these people would come out of the session, mom, dad, and child, and a separate individual would give them the questionnaire to fill out. After they fill it out, they fold it and insert it in a box that's all sealed up with just a slit in the top. So it's as much as possible independent information. And the therapist would do his or her rating as well separately. You can also notice that the children rate the therapist high on the alliance. The fathers are the more critical in rating on the alliance. But independent of those rater differences, the key variable is that CBT with or CBT without, treatment with or treatment without exposures show parallel growth in the alliance and no detrimental impact from the initiation of exposures. Okay, I'm talking fast. I do want to get through a lot, and we have a short period of time, so I'm going to keep winging it. Excuse me. The one study I want to emphasize for now is one of the big ones. 488 kids looking at the relative efficacy of CBT medication, in this case sertraline, and the combination versus a pill placebo. And you can see the various sites that participated in this study, many of which were medical centers, and these are kids with not just modest anxiety. These are kids going to psychiatry departments at major universities for problems with anxiety. One key feature that I like to emphasize, given my slant on things, is that CBT was low on dropout. I also noticed that the highest dropout was for pill placebo. I guess if you're assigned to a condition and you're taking something and it has no effect, you're likely to drop out, which is reasonable. But the CBT being the lowest in dropout reflects favorably on the fact that it's a tolerable approach to treatment. I might also add that the overall dropout rate was quite low. These were participants with severe problems, and I think they were receiving good treatment, so the overall rate's pretty good. Here's the take-home message on responders. And it says at the bottom of this chart, percent responder. I just want to give you a little detail. It's a 7-point scale. It's completed by an independent evaluator. The person who's doing it does not know which treatment the child received. And it's a 7-point scale. 1 is very much improved, 2, much improved, 3, improved, 4, no change, and then, of course, worsening. What's important to know here is that in order to be a responder, you have to be a 1 or a 2. 1, very much improved, 2, much improved, 3, improved. A 3, improved, is not enough to be a responder. These are just 1s and 2s. So the actual response rate would be a little higher if you included 3s. But we were being rigorous. Only 1s and 2s on this 7-point scale are treatment responders. Bottom line take-home message, you have 3 treatments that are effective. The combination of CBT, in this case coping cat, and medication, in this case sertraline, or those mono treatments alone, all better than pill placebo. If you look at the rapidity or the timing of the change in the 12 weeks of acute treatment, you find a quadratic effect. The black line, placebo, at the top doesn't have as much change. The combination treatment, the red line, has the most change. We're looking at week 12. And CBT and sertraline are about the same, but they get there at different pace. Medication effects were most obvious in the first 4 weeks. CBT effects were most obvious in the last 4 weeks. Medication effects are quicker, probably more noticeable. CBT effects are greater during exposure, the last part of the treatment. If you run it out further, of course, the pill placebo condition are now no longer available. They're receiving treatments as they request. And you go out to 36 weeks, you again see you have 3 effective treatments. The combination, CBT, and sertraline all doing quite well with some reasonable maintenance of gains for a large percentage, not all, of the kids. So what else has been found? And by the way, you're going to see some pictures of some students. I hope all students. I hope I haven't missed anybody or forgotten anyone. They're not necessarily linked to particular studies that we talk about, but I do want to give them some credit because without them, I've got nothing. So what else has been found? Well, let's look at therapist factors. Let's look at child involvement, and let's look at relationship building strategies. I'm going to be brief. When you look at codes of events that take place in sessions, collaboration, therapist, child working together as opposed to one teaching the other, collaboration is an active ingredient. Things like, you're an expert on you, I know a bunch about anxiety, we're going to work together and we're going to get that worry monster. It's a collaboration of child and kid against anxiety. Child involvement, the degree to which the child is an active participant, making some of the materials, doing the homework in the workbook, all those things. Active involvement is a predictor of outcome. And the third one of Tori Creed's projects with me, has to do with what are the ingredients in a therapist's behavior that, as rated by the child, are indicators of a good alliance. So the child rates the therapist's relationship and alliance. We have outside neutral observers watch the therapist and code their behavior. Which therapist behaviors predict the child giving them a high alliance rating? Guess what? Collaboration was number 1. Collaboration predicts a good relationship score. Interestingly, another variable predicted in a negative direction. Talking too much about anxiety too soon predicts a lower alliance or relationship rating. And there's an easy way to think about this. If you've read our treatment manual, you know the goal of session 1 is to have the child come back for session 2. That's the goal of session 1. And if you have a child come in for session 1 and they're an anxious kid, they're saying things to themselves like, what's it going to be like? Why am I here? I don't need to be here. What are they going to say to me? What are they going to do? They're bringing their anxiety template to the situation. We want them walking out with, that wasn't so bad. Hey, the catastrophe didn't happen. We want them coming back to session 2. So if you talk about anxiety too much, too intense, too focused in that first session, it's a turnoff. It reduces the relationship or the alliance. Okay, let's move on to some other things that we have found. This study with Tara Paris and our colleagues, Paris, I mispronounced her name, talks about how the trajectory of change from high anxiety to lowered anxiety is affected by the implementation of different strategies. So, for example, introducing relaxation training didn't significantly alter the trajectory of change. However, introducing changing self-talk and, importantly, introducing exposure tasks had a significant impact on the trajectory of change, those being reasonable active ingredients. What else has been found? Well, let's talk about moderators of outcome. And here, it's kind of hard to say because there's mixed findings. So I'm going to give you the sort of generic version of things rather than some of the details. But when there are details that are important, I'll try to remember to mention them. First, age. 7 to 17, there does not seem to be a difference in age for outcome. Now, age in this case is not really a moderator, it's just a predictor. Does differential age predict a differential outcome? If it were a moderator, it would be age interacting with different type of treatment. So I'm just talking about it being a predictor, although it's also true as a moderator. Kids of 7 to 13 or 13 to 17 do comparably well. There was a little bit of a to-do about adolescent mice not doing as well with exposure, and the assumption being therefore that adolescent humans wouldn't do as well with exposure. But in a review that I and Jeremy Peterman did and published in the American Journal of Psychiatry, there's no difference as a result, associated with age. Similarly, for comorbidities, some studies find a hint or two. Many find no difference by comorbidities, and in our work, the attribution for or explanation of this is as follows. Therapists make adjustments when kids bring their comorbidities to treatment. So, for example, if the kid's anxious and a little ADHD, the ADHD may be medicated. The ADHD may result in the therapist altering the duration of treatment or taking more breaks or having more opportunities to rehearse things. In other words, good therapists are making adjustments, not letting the comorbidities be ignored. They're not the treatment target. We're still targeting anxiety, and that's our goal. But they're making some adjustments, so that may reduce the impact of comorbidities on differential outcomes. Severity, sometimes you do find that the more severe are tougher cases. And as we'll see when we get down to family distress and family dysfunction, it's often the family distress and dysfunction that may be explaining that. You know, there's maybe a single parent, or maybe they don't own a car, or maybe they're poor, or maybe there are multiple kids, and maybe there's a child with a severe mental health problem like autism or retardation or some severe developmental problem. And so the mom or the dad, whoever the single parent is struggling with all this, and it makes for a greater severity of the difficulties, not just the anxiety. Excuse me. And last, on this parental psychopathology, I just want to mention, if a child has a parent, mom or dad, with an anxiety disorder, they do comparably well in treatment. From pre to post, the presence of a parent with an anxiety disorder does not differentially impact outcome. However, in at least one study, and I know of 2 or 3 where the findings are similar, the presence of a parent with an anxiety disorder at 1-year follow-up, while all kids in general maintain improvements, not everyone, but the majority, those who have a parent with an anxiety disorder, they maintain their gains less well. So parental psychopathology, or presence of a parental anxiety disorder, does have an impact on the likelihood of full maintenance of gains. They have a depleted maintenance of gains. Again, I apologize, I'm talking quickly, trying to get a lot in. Let's look at mediators. I'm going to be brief. Change in self-talk was a mediator of change in 2 studies. Change in the child's perception of their ability to cope was a mediator in 1 study. And in a study of just medication, just the sertraline condition, a change in physical symptoms was the mediator of change in the medication condition. So you can see that the cognitive change, the self-perception of coping, were mediators in the CBT and in some of the combined treatments, and the physical symptoms was a mediator of change in a medication treatment. When you go to follow-up, we have some good data. One thing that kids remember at 3.5-year follow-up is the therapist's name. I think it's a reflection of a good relationship. They also remember, you made me do things I didn't want to do, which I think is a good reflection on the importance of exposures. They did not, however, recall at 3-year follow-up a lot of our sophisticated, psychological, theoretically important topics. It was a little disappointing that some of the stuff in our more heady explanation of change wasn't really supported by the kids. They remembered, take a deep breath, you made me do things I didn't want to do, and they remembered it favorably. It wasn't a mean-spirited thing. And they remembered the therapist's names. So, at 7 to 19-year follow-ups, we have some good data. We have some data that suggests successfully treated kids at these long-term follow-ups compared to unsuccessfully treated kids from those same studies. Those successfully treated have reduced suicidal ideation, and in some studies reduced substance use problems. So you've got some nice reduction of the sequelae of untreated anxiety when you are successfully treating anxiety in the youngsters. These are some citations and some faces that go with them for some of the previous work that I just mentioned. Recent study of functional outcomes, kind of cool. I'll let you read the slide. Just a quick summary that participants who received the CBT, this was the coping cat in the CAMS study, compared to the pill placebo, when followed up 6.5 years later, had overall improved impairment, overall better life satisfaction, better academic functioning, and better self-care and independence. And that's important because the trajectories for the medication condition and the trajectories for the combination condition on those same variables were not significantly different from placebo. So there's something about that CBT alone condition that had some long-term follow-up benefits. What else has been found? On the sort of less favorable side, social anxiety seems to be tougher to treat. When you get socially anxious kids and you follow them up later on, their maintenance of gains, while they're there, they're not as good as the kids' maintenance of gains if they had other kinds of anxiety when they were treated. And of course, with some follow-up, there are some moderately severe cases that had not so good outcomes, and over time, those folks may need some boosters. Here's what I consider a reasonable generalization, and I'm rounding some numbers, but I'm giving the big picture. For placebo, or really for treatments that might be considered alternate theoretical approaches, you can get 20-25%. For active comparison conditions, and we have examples of studies that have these. Jennifer Silk has done some, Ellen Flannery Schroeder's been involved. One of the ones we did is cited here. You get about 40%. If you do a brief CBT, which is quick, eight weeks, you get about 40%. When you do a full 16 weeks, and sometimes it's 18 weeks, sometimes it takes 6 months because there are holidays and things, but when you do a full implement of CBT, you get about 60%. A few things to say here. 60% is really good. It's not 100%. We all aspire to 100%. We're not getting it. It's tough. 60% is damn good. And I feel confident and pleased that we get to that level. But unfortunately, when we talk with some of our mental health colleagues who are not CBT oriented, they sometimes say, oh, I tried it and it didn't work. That's an N of 1, and it may be the first time you tried it. When you get better at it and when you have more cases, put them together and look at the data in general, and encourage people not to be dismissive right away. 60% is better than 40, and 40 is better than 20, and we have ways to go, but this is one strong justification for empirical approaches, because they tend to do better, and they tend also to give us some evidence about where we need to improve. What else included in what we don't know? I think it's kind of sad we don't know anything about what to do for non-responders. I think psychiatry, when they have a non-responder to a medication trial, they punt over to psychology. And unfortunately, psychology, when we have a non-responder, we punt over to psychiatry. I want to do a study of how best to treat non-responders. And as you can see, we also don't know as much as I'd like about the best way to disseminate empirically supported treatments. And one of the faces you see in the pictures of students here is Hannah Frank. Her dissertation is working on a topic of interest, and you'll also see Leslie Norris's picture there. She's also working on a topic of interest, and there are some others whose pictures aren't on this particular slide, Kate and Margaret. We're all working on things about what are different ways to disseminate and which ones are more effective. One of the things I find kind of interesting is if we could get on Oprah and have the people in the real world hear about it, or even the Jimmy Fallon show or some second-class radio program, if we could get on those mass media efforts and have the parents be informed about what to ask for and how to check that they're getting what they should be getting, I think we're going to have a beneficial impact down the road. Right now we seem to be working on training therapists. Maybe that we should train the receivers of treatment to know what to ask for. So those of you who have needs for studies, call me, let's collaborate on that, because I'd like to work on that. Next steps, increase awareness. Identify in primary care and schools if we can. Do some more person-centered analyses of outcomes. Consider some RDoC. One RDoC feature that I really think is important is intolerance of uncertainty. Flip the meaning of that. It's best for kids to be able to tolerate uncertainty. Anxious kids have an intolerance for uncertainty. I think that's an RDoC kind of construct that has some predictive power. Address youth's next, I'm just going to turn off that phone. Address youth's next developmental challenge. Address parental accommodation. And address computer-assisted efforts. It didn't get turned off. Okay. Computer-assisted efforts are valuable as well. These are some efforts we've made. I want to be honest and disclose that I receive a modest royalty for sales of some of these computer-assisted materials. The program for youth is called Camp Copilot. It's now an online version. The program for therapists is CBT for CBT. And the program for parents, these are all done with myself and Munia Khanna, is called Child Anxiety Tales. It's kind of cool that we can combine with the computer and with technology and with the internet, but a word of caution, screen read is not enough. There's got to be some contact with real people who will get those exposures done. And in all of our approaches, we emphasize that and make it clear. Some other people who've helped out, I hope I didn't leave anyone out. If I did, they're under the et al. Category. Here are some others. NIH, NICHD, the MacArthur Foundation, they all deserve some thanks as well. And if your name is up here, I need a picture of you to include. Send me your picture. Some conclusions. CBT can be an effective treatment for youth anxiety and evidence of maintained gains and positive functional outcomes. We should applaud that. It's a result of a lot of work by a lot of people. It's a good outcome for psychology. But not all youth benefit. There's definitely room for improvement, and we need to know what to do with non-responders. A take-home message that will not be surprising to anyone is that talking is not enough. If the therapist is sitting in a room talking about anxiety and they don't get out and practice coping in the real world, it's not enough. Exposure tasks or behavioral experiments are the key to improvement, and that's where we will end. Thank you for having me do this. I hope I didn't go too long, and good luck. Best wishes, everyone.